Hello everyone, welcome to another Endocrine podcast organized by the Sri Lanka College of Endocrinologists. Today we are going to discuss about Addison's disease, hormone replacement, stress dosing and management of Addisonian crisis. Adrenal insufficiency could be primary, secondary or tertiary. And primary adrenal insufficiency, also called Addison's disease, is due to diseases in the adrenal cortex. Secondary adrenal insufficiency is due to disorders of the pituitary gland leading to corticotropin or ACTH deficiency. Tertiary adrenal insufficiency is due to disorders of the hypothalamus leading to corticotropin releasing hormone or CRH deficiency. In primary adrenal insufficiency, it's associated with both cortisol and mineralocorticoid deficiency. In contrast, secondary and tertiary adrenal insufficiency are associated with cortisol but not mineralocorticoid deficiency, because aldosterone is regulated primarily by the renin-angiotensin system, which is independent of the hypothalamus pituitary axis. This distinction accounts for the different clinical presentation and management of these disorders. Next, we'll talk about steroid replacement in Addison's disease. We try to mimic the physiological diurnal variation of serum cortisol levels with peak levels in the morning and lower values towards the end of the day. The usual hydrocortisone maintenance dose is 20 mg per day taken in 3 divided doses. 10 mg taken in the first thing in the morning, followed by 5 mg around noon and 5 mg around 6 p.m. However, the total daily dose and the splitting of doses could vary depending on the individual patient requirement. Hydrocortisone is always preferred as the replacement therapy. However, if hydrocortisone is not available, you could use prednisolone 5 mg daily or dexamethasone 0.75 mg daily to provide steroid cover until hydrocortisone is available. Then you need to start fludrocortisone 100 micrograms daily to cover mineralocorticoid deficiency. This is especially important if patient has low blood pressure, postural hypotension, hyponatremia and hyperkalemia while on hydrocortisone. You can monitor adequacy of hydrocortisone replacement by clinical assessment of patients' symptoms of low cortisol such as weight loss, postural drop. You can monitor adequacy of hydrocortisone replacement by clinical assessment of patients' symptoms of low cortisol, weight and postural drop. Cortisol day curves can be done if you are in doubt, but the usual recommendation is to go by patient's clinical features rather than by day curves. Fludrocortisone replacement can be assessed by monitoring clinical features such as salt craving, postural drop of blood pressure, and serum electrolytes. For women with Addison's disease having low libido, you can try a trial of dihydroepiandrosterone or DIA. Remember, patient education is the key to successful management of adrenal insufficiency. The patient should be informed that they can lead a normal life as long as they take treatment properly. The patient and family members should be educated about the nature of the hormonal deficit and the rationale for treatment, steroid medication and adjustment during minor illnesses, and when to see the doctor and when and how to inject hydrocortisone for emergencies. They should be provided with steroid card to carry with them always. Patients should be educated on stress dosing. During febrile illness, they should double their hydrocortisone dose until clinical recovery. But if the patient has severe illness or illness lasts more than 3 days, they should see a doctor immediately. No adjustment is needed for minor OPD procedures like a dental extraction. However, for major surgeries, patients need to be put on IV hydrocortisone. If patients develop vomiting and unable to take oral medications, they need to visit the hospital immediately. Finally, we'll talk about Addisonian crisis or adrenal crisis. Adrenal crisis is a life-threatening medical emergency. It's a form of acute adrenal insufficiency presenting with hypovolemia and hypotension. The cardinal rule in managing adrenal crisis is that the treatment should not be delayed until the results of the diagnosis are available. You need to act immediately. First, insert an IV cannula and take blood for serum cortisol, serum electrolytes and plasma glucose levels. Then give a bolus of normal saline followed by a normal saline drip. You may need to give 2 or 3 liters of normal saline depending on the patient's volume status. Give IV hydrocortisone 100 mg immediately followed by 50 mg every 6 hours or 200 mg per day in continuous infusion over 24 hours. If hydrocortisone is not available, you could use IV dexamethasone or IV methylprednisolone. And do other investigations and supportive measures depending on the clinical features of the patient. Look for underlying sepsis and treat if necessary. Find out why the crisis has occurred and take necessary steps to prevent this from happening again. Once the patient is stable, switch back to oral hydrocortisone. And thank you, and we'll meet in another podcast.